Welcome to the external webinar, bioCADDIE external webinar. So in today's presentation, we're going to have Dr. Sheng and Mark Velez. So Dr. Sheng is a postdoctoral research scientist currently working at the Columbia University, Department of Biomedical Informatics. She received a Bachelor in Medical Information Sciences at China Medical University, and she received her PhD in Health Informatics from the University of Texas Health Science Center at Houston. She currently works for George RIPSAC BD2K Administrative Supplement Project, developing a system to assess suitability of clinical databases for observational research. And Mark Velez is the technical lead for the clinical data warehouse team at Columbia University Medical Center. He received a Bachelor of Science in Computer and Information Science at Brooklyn College and Master of Arts in Biomedical Informatics at Columbia University. He currently leads the technical architecture at Columbia University, the Central Coordinating Center of Observational Health Data Sciences and Informatics. So in today's presentation, they're going to talk about ACHILLES, a platform for exploring and visualizing clinical data summary statistics. So please welcome Dr. Sheng and Mark Velez.
Thank you, Khalil. Thank you for the nice introduction. So today we will start from introducing OHDSI and then focus on ACHILLES, one important OHDSI application. We then proceed to elaborate ACHILLES applications. This will include applying ACHILLES for our bioCADDIE DDI suitability prototype implementation. OHDSI stands for Observational Health Data Sciences and Informatics. It grew out of a National Pharmacovigilance Consortium, which is OMOP, Observational Medical Outcomes Partnership. This OHDSI program is a multi-stakeholder, interdisciplinary collaborative consortium. Our community engages activities from researchers, patients, providers, payers, and others. They are from different backgrounds, including medicine, biostatistics, computer science, and informatics. The OHDSI consortium is to bring out the value of observational health data through large-scale analytics and evidence generation. Observational health data refers to the data that is collected during the real-world healthcare delivery. This data may be captured by doctors in electronic health records, or by insurance companies in claims data, or by public health agencies in registries. The great value of observational health data is the capacity to study research questions from millions of patients' experiences. So, what kind of research questions we can ask? One is clinical characterization. By characterizing the data set, we can describe a natural history of a disease or patterns of a drug used for a disease. Another research question is about population level estimation. Take pharmacovigilance as an example. Researchers use the larger data set to detect rare or new side effects for drugs. With lots of evidence generated from the observational data, we can use it to predict individual health outcomes. For example, by incorporating evidence from similar patients who have similar medical history, we may provide personalized treatment recommended for a patient. So, to answer the above research questions, we need sufficient data. However, no single observational data source is likely to be sufficient to meet all expected research analysis needs. So there is an interest in accessing and analyzing multiple data sources at the same time. But study data from different sources is challenging because data custodians use different models to collect and store patient data. In most scenarios, observational data cannot be shared. So in OHDSI, we use a common data model to store patient data. This enables organizations to standardize multiple data sources format in a standard data format and allows different analysis programs to query the data at the same time. By 2014, there are about more than 50 different data sources represented in OMOP CDM. The original data are administrative claims, electronic health records, health information exchanges, hospital billing data, or clinical registers, and the national surveys. The data is from 9 countries, so there are more than 250 million patients across different data sources. So this is the mission of OHDSI. OHDSI is a community that actively engages with collaborators, and everything developed is open source. In this slide, we illustrate OHDSI infrastructure. Multiple data sources in different data formats are transformed in OMOP Common Data Model, CDM. And from this common ground, the OHDSI community can develop and execute large-scale statistic analysis from multiple data sources concurrently, for example, treatment pathway project. In addition, this common data platform also allows for developing analytic tools for different purposes, for example, ACHILLES for visualization of summary statistics. To this topic, I will come back later. So let's look at OMOP CDM first. OMOP CDM was first developed in 2008, and now it's in its 5th version. Right now, both CDM4 and CDM5 are commonly in use. The common data model refers to 2 commons. One common is a common structure. It defines a unified data storage model. Another common is common vocabulary. OMOP vocabulary has mapped public or commercial terminologies such as SNOMED CT, ICD-9 to a standard vocabulary. The standard vocabulary is a semantic network to describe the meanings and structures of the data we see in the CDM. All structured data in the standard vocabulary format, which can be easily queried for observational analysis. There are several principles in the CDM development. CDM is a person-centric modeling. All tables have foreign keys into the person table and a date. So this allows for longitudinal view on all the healthcare relevant events. The data is split into domains, for example, conditions, drugs, procedures, and observations. Observations are mainly labs. In addition to clinical data, metadata about data derivation, and health system data, and health economics data, and research data for cohort can also be recorded in the CDM. So the ETL process for the OMOP CDM is implemented differently in each institution. However, OHDSI provides open source tools for the ETL process. After introducing the OHDSI and OMOP CDM model, let's focus on ACHILLES. ACHILLES is an open source analytics framework that builds upon CDM data. ACHILLES is to enable interactive exploration of the pre-calculated population-level summary statistics of patient-level observational health datasets. However, the purpose of this tool is not to view clinical data for care. It's to experimentally explore the statistics about the data. The data are separated from or protected from visualization by using aggregated data. So later, researchers feel like they are exploring the data without accessing the data. Patient privacy is protected. We think this is very important for DDI because ACHILLES provides a way to centralize summary statistics without accessing the database. ACHILLES needs to be run only once for each CDM dataset. But if new data comes in, we need to rerun the Achilles. So this is a hybrid R web-based application. Currently, Achilles can support different cycles. It can also specify minimum cell size to enable data sharing. Specifically, summary statistics are queried on the CDM data and stored as strata tables. Then Achilles heel, which is about data quality, is queries from generated strata tables. These results are exported into JSON format and then subsequently visualized in a web browser using Achilles Web. So now we have an overview of Achilles. We want to demonstrate how to explore Achilles in the following sections. Achilles has each report web page for each clinical domain. For example, dashboard report page, person report page, conditions report page. Now let's walk through Achilles by different domains and the analysis tabs. Let's start with the overview of the clinical data set. This is the dashboard report page. In the navigation bar, there are data sources and reports buttons that you can choose different data sets and change into different report pages. Here we have OHDSI sample database and the simulated Medicare data for the demonstration. For summarizing the clinical data set, Achilles provides information on the size of the database, gender distribution, persons with observation period. Achilles can also present demographics of the population covered by the database and the demographic information over that event. So in person page, the detailed overall demographic information about the gender, race, and ethnicity distribution are presented in pie charts. Age information is presented in a histogram. The death table is designed to capture the time when a person is deceased and the types of how death is recorded in the database. This is visualized into death prevalence stratified by age, gender, year, and month. Types of death and age and death are also presented here. Summary of metadata is also retrieved. Observational periods are used to describe the time intervals that clinical events are captured in the dataset. Data density describes the quantity and the quantity of data records or concepts per unit measure. Data density can show how much information is recorded in one patient. One person may have one or more disjoint observation periods. So observation length or duration is calculated from the first date and the last date for person's data is available from the data source. Information of age at first observation and duration by gender can be retrieved. This is the page for data density. Data density presented here includes the number of records from different domains for each month, distinct clinical events concepts from different domains for each person. The domains are clinical domains are visits, conditions, persons, and others. Achilles provides prevalence information for all clinical domains. And the condition and the drugs also have euro tables. And euro refers to a span of time when a person has a particular condition or takes a particular drug. In Achilles, there are three views to visualize prevalence: tree map view, table view, and the drill down view. So now let's use condition as an example to illustrate each view. So this is tree map view. Tree map view is to display hierarchical data by using nested rectangles. This view highlights condition prevalence with box size and the number of records per patient using box color. Areas of tree maps separated by thick white lines represent groups of related conditions. If you move your mouse onto a box element, the prevalence summary information is displayed. If you click a box element, a drill-down view for this condition will be triggered and displayed below. So alternatively, you can also display prevalence information in the table view. Now, this is the triggered drill-down view for selected condition. The drill-down view is to show detailed demographic information of selected concept. The first is to show the frequency of a condition in different age group, different gender, and different year. The second is to show the prevalence for each month. The drill-down view also shows the types of the selected conditions. So the condition type may be defined as primary or secondary condition, or defined like this pie chart shows here is by different carrier claims detail. Age at first diagnosis also provides useful insight for researchers. Now we move on to last part of Achilles summary statistics, Achilles heel. Achilles heel can identify data errors with predefined rules. Achilles heel generates a list of errors and warnings. You can search through these messages and export them for further analysis. You can also use Achilles heel report to revise and improve your ETL process. So, what kind of information does Achilles heel check? What kind of errors do they find? So from my point of view, these rules are defined to check errors from documented clinical facts in different domains or from terminology. Errors of documented clinical facts include illogical changes. For example, change of condition count between 2 consecutive months is more than 100%. And the data may contain invalid ID. For example, person table may contain a link to invalid provider ID. And then improper value based on a reference standard. For example, the year of birth is earlier than 1800, and the payment is number is a negative number. The last clinical fact error is improper value that based on logical relationships between entities. For example, documenting a condition for a patient after the patient is dead. The second type of error is from terminology. This includes the concept is not a standard OMOP vocabulary concept, or the concept is not mapped to a OMOP standard vocabulary, or the concept is mapped to wrong vocabulary. For example, drug is not coded with oxynorm. Now we demonstrated how to use Achilles as its own. Because this is de-identified summary statistics, so it allows data sharing in a public domain from patient privacy point of view. There are also some other applications for Achilles. One is to integrate it into hospital clinical systems. It provides very nice visualization for doctors who want to get a big picture of patients or a specific clinical event. Secondly, Achilles can collaborate with other OHDSI tools to help research. Achilles is a modular development environment. Each application has its specific function. They work together to finish a research task. We also think that Achilles can be used for other applications. For example, our bioCADDIE DDI project is to evaluate a clinical database appropriateness for research use, which is suitability. We are implementing suitability prototype using Achilles. One of the scenarios that Achilles tools work together to finish a research task is about cohort identification. So for this task, we first use Achilles to look through the data set to find out if the condition that we are interested in is contained. Then we use SERSI to define the cohort for the condition that by specify the name of the condition and by different filters such as a temporal filter, or we restrict the demographic information. Then we save this cohort and export this cohort to Heracles. Heracles is to summarize the cohort and visualize the summary statistics. Heracles is very similar to Achilles' summary statistics, but just only for the selected population. But you also can, for Heracles, you also can filter and run different analysis. So right now, SERSI and Heracles are still under the development. Now, OHDSI is also developing OHDSI Launcher 2 and the Web API, which are designed to simplify the configuration and usage of OHDSI tools. Our BD2K DDI project is to characterize clinical databases and evaluate their suitability for observational studies. This project is to help researchers to narrow down a database of interest, but avoid to do unnecessary work to obtain all the access to different clinical databases which cannot meet their research needs. So in this project, we developed a conceptual framework. We call it the suitability framework. We are also implementing a prototype within Achilles. So suitability in general science is the quality or state of being especially suitable or fitting. In our project, we define suitability as the extent that a clinical data set can meet research needs for observational studies. As we know, right now there are a lot of observational studies that use clinical database and discussion about how to reuse these databases. But the literature concerning data suitability is modest. So we start to find out what aspects are important for data suitability by developing the suitability conceptual framework. This is our research methodology flow. So to develop the framework, we reviewed population-based observational studies using clinical database to find the researchers' data needs. We also surveyed clinical database desiderata studies to understand the challenges and that researchers face when they want to reuse clinical databases. Each topic review showed a list of operational features of how clinical databases suitability could be assessed. We call these features sub-measures and then group them into a higher level constructions, such as measures and categories. Right now we are conducting a web-based national survey to validate the framework. We are also developing metrics to measure suitability and implementing the prototype within Achilles framework. This hybrid approach will assist in indexing databases and will help researchers to better choose clinical databases based on their research needs. This is our suitability framework. As we mentioned earlier, the suitability framework groups attributes that describe or characterize clinical databases on their utility for research into categories. So here, 5 categories we defined are from researchers' point of view. So first, to help researchers access the data, policy and administration principles to guide researchers on how to access clinical data and how to query the data. To inform researchers what's contained in the database, relevance and descriptive metadata and provenance documentation are defined. Relevance is the extent to which the data and the information contained are pertinent to research of interest. We're evaluating relevance by specifying health organization data and how data organized in the database, and the available data inventory, and the retrievable temporary information. Metadata is also available to understand the data's information arranging and the intellectual content. So this refers to as data provenance and the content synopsis. To assure that data can be used for researchers, so usability is to demonstrate the extent that the data can be used for research of interest. This emphasizes how data represented and available cohort and if the data are linked. Quality refers to completeness, correctness, and other essential characteristics that determine the reliability of the data for research. This quality evaluates from data quality component and overall data quality and the cohort quality. So because this is a conceptual framework, we are not only define and optionize the concepts, we also want to know between these identified categories, this concept, what's the relationship between them. So we view this relationship of categories through connecting them through general data characteristics like accessibility, representation, intrinsic, and contextual. For example, usability depends on the task at hand and reflects data contextual feature. So, and then to be a good use, data representation is important to retrieve the data. So usability also reflects data representation feature. Now we are conducting a survey to get expert feedback about this framework. Here is the URL. You are more than welcome to participate. As we mentioned before, we are implementing a suitability prototype. As an application, our suitability prototype evaluates the appropriateness of clinical database for observational studies, and then we want to dock this prototype to DDI prototype by applying the DDI prototype requirements. Since the prototype is built on ACHILLES framework, so ACHILLES here functions as an aggregator to cover different distributional clinical databases which are stored in the common data model. So we can focus on the suitability metrics and directly write queries without worrying about different schema. So the prototype will also comply not only with bioCADDIE's goal of helping the users to find the data, but also with the bioCADDIE development module. So OHDSI as a community, there are 3 major websites, the organization website, the GitHub developer website, and the forum website for OHDSI members. I also list the ACHILLES related websites, especially the demo website. You can go there and check it out. And with this concludes my presentation. Thank you. I know this is probably a lot of information, and I talk probably too fast, but now we are open to questions.
Okay, we're going to unmute all lines and open for questions.
The conference has been unmuted.
Hi, this is Hyunhee Kim from UCSD. This is a really great talk, an exciting project. So I have a quick question about the data suitability conceptual framework. So you said you're conducting survey.
Yes.
To make sure that the validity and usefulness of this conceptual framework. So do you happen to have any paper or some sort of materials that we can refer to if we want to use prematurely your this data suitability framework for some other study? Is there anything that we can refer to?
Right now, actually, so far we haven't published yet, but we are putting a draft right now. So we hope, because this draft we want to specify what is our framework and also get the survey results back and to validate.
Right.
And we hope we get everything at least prepared in September.
I see. By September. Okay. Yeah, I find this framework really useful.
Thank you. And actually, because we, like I mentioned in the presentation, right now there are about the data, this quality, everything is very hot topic. When I want to find how to, if there is any suitability framework there that for us can evaluate how the useful of each clinical database. Actually, there are not many studies, so we think this suitability framework will be helpful in this direction.
I see. Thank you.
Thank you.
Cleo, will this presentation be available to all the attendees? As I'd ask, I'm sorry I didn't catch the name, the lady who just spoke, to please contact us if she'd like to find out more or perhaps collaborate on some of these efforts.
Yeah, so we're going to make all the slides and also the recording for this webinar in our website. And so probably later today, once we finalize this, the webinar, we need to process all this material. So later today, we're going to make it available in the website to you, so you can visit the bioCADDIE.org. And all the presentations, not only this one, but all the other webinars are also available in the website.
And I also have one question. Since right now the survey is still open, so we also want to invite CDI group, bioCADDIE group, to give us the feedback for this framework. Can I later on send out this survey to the group?
Oh yeah, definitely. So what I can do is we have a list of the attendees for this webinar, so we can send out the survey as in an email, and we can also include the bioCADDIE team with the survey link. So we can ask them to participate and give some answers for the survey.
Great. We really appreciate that. Thank you.
No problem. Sure.
Hi, Sunny. This is Anu from UT Health.
Hello.
I have a quick question about the conceptual framework that you presented.
Yes.
Did you do any kind of user needs analysis before you put the framework together, or was it like something that you came up with and now you're doing a survey?
Actually, we didn't do the user analysis, but because our users in this case are researchers, so we look at all the literatures about the studies that the researchers use clinical database for their own study, and we focus on the how they describe the data set and the background information about this data space. And then also focus about the discussion part that the researchers say that, we use this database, but we found out this and that, the data is not reliable somehow. We put them together as one part of the characteristics that describe when the researchers want to use data, what's their needs, and what's their wanted functions from the data. But after that, we think it's sort of not complete because that's total from research point of view. So we also review the clinical database from data custodian's point of view because they offer data. So they also have a list of the things they want to provide to researchers, and then we combine these two together. And at the same time, we also incorporate a lot of data quality studies factors inside. So this is right now the survey. So we have the conceptual framework first. So we basically use bottom-up method. We have all the factors, and then we group them into measures and categories. And then right now we are doing the survey to retrieve the feedback from the people that use data for their studies and to see if they agree with the categories that we come up or the specific metrics we come up. And we hope, and we think this is an iterative process that we will revise our feedback framework based on the feedback.
Okay. So who are you targeting the survey to?
So right now we are targeting, of course, our OHDSI group. So our OHDSI group has, first, they are data users, and also at the same time, they also provide data. They also host the data. So we are target group that has the data, use data experiences, and all want to use data for research. All data custodians that they have the host the data and want to provide data for researchers.
Okay, thank you.
Sure.
Any other questions?
Actually, I have one more quick question about the various views of the data presentation. So do you happen to notice any preference from the user side on the particular view of presenting the data?
This part, I haven't really looked into this part, but with presentation, because ACHILLES is a visualization tool. Right now, our implementation is on top of ACHILLES, use their existing visualization. But I think if we really want to know how to represent, how to visualize data, then for users, they can really explore data as a very good experience. Probably we may need to really test from users for the visualization. But so far, I don't have any experience for that.
Okay, thank you.
Sure.
Any other questions?
Hi, this is George Alter at Michigan. I have a question about how you define cohorts, which you mentioned. What's the dimension along which the time dimension you use for cohorts?
I think in this case we use a cohort for our usability. If for research we very simply just the demographic information and the temporal information, select the study range that the study range that related patient are selected. Another part is about variables, which is what is the research variable you are interested in, conditions, specific conditions of drugs. I think that's right now this 3 dimensions.
Okay. Well, I'm not. So, I mean, one way to define, I heard several things going on there, and when I think about a cohort, I think about some sort of event that starts the timing of the cohort, which could be a birth cohort, that is to say all the people who were born in the same year, or it could be a cohort defined by some sort of event, such as presenting themselves, some sort of disease event, say a heart attack, or being admitted to the hospital as a starting event, and sort of so that event defines what time 0 is, and then time is measured from that time point. Are you thinking about it that way or some other way?
Yes. So the slide that we presented here was regarding the tools that OHDSI provides, one of which is called CIRSI. It's a cohort identification tool, and it's one of many other tools that OHDSI provides. But basically what it does is exactly along the lines of what you're describing. Basically, using the common data model, one is able to kind of have a standard representation of how one can define a clinical population, a cohort. And that can be based on what their date of birth is, what clinical conditions were observed and when, and any combination of all of these factors. So one of OHDSI's goals is to provide a framework which would allow clinical researchers to define cohorts of, of all these various types of cohorts using different methods.
Thank you. That's very interesting. Thanks.
And so if, OHDSI is welcoming all clinical researchers, anybody who's interested in collaborating on these. There's obviously statistical analyses and frameworks like we described here, but there's also a lot more. So we invite you to check out the website, ohdsi.org, and it should be on the slide deck, but that's spelled OHDSI, not the way you typically spell OHDSI. So do check that out. All of these tools are developed in an open source environment, so that means nothing is hidden from you. We have open forums where you can contribute and be a part of the direction that OHDSI takes. Sorry, I went on a tangent there. Do we have any other questions?
Okay, I think I have one question. So it looks like Achilles worked with the data that is in OMOP CDM.
That's right.
But is there any place in a website that, for example, if I have data that is in a different format, such as have EPIC data or Cerner data, is there any place that I can find information to transform that data to OMOP? Or how can I do that? How can I find information or guidelines?
That's a great question. So certainly with commercial products, we won't necessarily be able to provide you a direct point-to-point, how do you get from this to that. However, in the OHDSI repositories, we have a GitHub site where we have all of the, we publicize all of our code, and among those codes are our ETL kind of script. So an ETL is basically a process, a program that takes data from one format, and moves it over to another format. So the ETLs that you'll find in the OHDSI repository target the OMOP CDM upon which all of the tools depend. And so that might be a valuable resource if that's what you're trying to do. The forums are also a good resource because you might find other people who've already accomplished the sort of thing that you're trying to do. So I would point you there as well. Does that answer the question?
Yeah, perfect.
Okay.
Thank you. Okay, any other questions for Mark or Sunny? Okay, so I think we can end this webinar today, and thank you for both presenters for this great presentation. And we're going to have our next webinar next month. We have usually in the second Thursday of each month. So we're going to send the reminder invitation usually 1 week before the webinar. Okay, so thank you.
Thanks for having us. Take care.
Thank you.